Welcome to the CCG board meeting. Welcome to the board meeting. Yeah, the football pundits had us up leading. That's all right. Welcome to the meeting. We've had some apologies for today. David Evans, the accountable officer, is unavoidably in an NHS England regional meeting. Maggie Bailey, who is or will be the interim director of nursing for a week's time or so, is at a national meeting. Fran Beck is unavailable, and Rachel Robinson, the director of public health, I imagine is coordinating things elsewhere with more sudden pressing priorities. First thing on the agenda is declarations of interest. These are above and beyond the ones that are declared on the websites. If I go around the board, starting with Alan, and if anyone any.
No. No, thank you.
No, thank you.
No, thank you.
Not for me.
Thank you. Go through the minutes in a minute, just to say that we may move the agenda around slightly just because of other commitments that board members have, particularly around the emergency planning that's going on at the moment and some of the other pressing work that the CCG has got to do. So we'll be moving Alison Smith's update on the single strategic commissioner to the first paper after matters arising before the clinical financial report. And then at some point we will fit in Sam Tilley's update on emergency preparedness, resilience and response, depending on meetings, and we'd probably aim to have that around sort of 2:30, so either just before or just after the break. So if we move on to the minutes of the previous meeting. Oh, before that, I do have some comments, sorry. I've got a few goodbyes and a few thank yous. It's some people's last board meeting today. It would have been Fran Beck's last board meeting, and it is Christine Morris's last board meeting. So thank you very much for the work you've given over the years to the health economies, both here and elsewhere. So thank you very much. And it is actually the last public board meeting for Dr. Sokoloff, who's moving on to other workplaces within the NHS. So thank you very much also for your last few years' involvement and leadership within the local health economy. So thank you. Okay. And then if we move back to the minutes of the last meeting, this is the meeting held on the 15th of January. And if we do them first of all for accuracy and corrections, so if we go through from page 1 through to page 5.
I've just got one on page 4, I think it is. Hold on, let me just check. No, page 3, sorry. Under the section 8.1, there are a number of bullet points in terms of my presentation. The 5th one down says, unfortunately, the savings achieved are just holding the forecast position and preventing it from worsening. I think that should say, fortunately, the savings achieved are just holding the forecast position and preventing it from worsening. It's unfortunate that they couldn't make it any better, but it's definitely fortunate that it didn't get any worse.
Thank you. I did read through the minutes and obviously had a different understanding of unfortunately. Thank you. So page 6 through to page 10. And then page 11 through to page 15. And then page 16 through to the end, which is page 17. Thank you. So then move on to the actions that aren't complete or ones that aren't coming up on the on this meeting. So the first one of those is I was going to write on behalf of the board to Neil Mackay to ask what further steps could be taken to the system to try and improve patient experience. I did ask Dave Evans to write that letter, and I think it's still being in the process of being written, but I have actually spoken to Neil, and he is coming to a future board, and it's one of the things that we will raise with him, but we still do intend to to write the formal letter, but it is in hand. Next one we move on to is Masterising 2020-01.10, and that's for Dr Davis to update the governing body on progress of work resulting from the alliance agreement with providers for the new model of care for integrated provision of MSK services across Shropshire, Telford and Wrekin.
Thank you, Julian. So I'm pleased to say that the provider alliance has now been expanded to include both CCGs. So we're now finalising a full alliance agreement between Shropshire, Telford and Wrekin CCGs, Robert Jones and Agnes Hunt, the Community Trust and SAF. And that's progressing, and we hope to have we will have the agreement agreed by the end of March. That will include the financial envelope as well that we've discussed around how we manage our MSK demand through the system. So what I was going to propose was that I bring a detailed update to governing body in May. The MSK Transformation Board met for the last time at the beginning of the month, and that's now been taken over by an alliance board, again with representatives from all 5 partners. And again we'll have what I was going to propose is I'll bring the update from the alliance board through to the governing body in May.
No, thank you very much. Any questions on that? No, if not, we'll move on. I think the rest of the actions are either ongoing. There is one which related to Health Watch Shropshire, but I do have noticed that Lynn's not arrived yet. We've not had her apologies, but I assume it might be a parking issue. So we will raise that. Okay, we can raise that out of the meeting with Lynn. That's good. We then move, if we move on then to the first paper, we have had some questions from the members of the public, and they're on the seat. We did have one question that arrived after the cut-off point, so that will be taken forward and will be answered for the next public board meeting in 2 months' time. So thank you. We then move to Alison Smith's paper on the Single Student Commissioner update.
Thanks, Chair. So this paper is just giving an update to the board in terms of progress for our application to become one single strategic commissioner, one CCG in April 2021 across the Shropshire, Telford and Wrekin footprint. I wasn't proposing to go through all of the report, but there are a couple of things I wanted to highlight specifically. The first one is on section 2.3 around public engagement. We've obviously undertaken public engagement to seek views on the proposal to create one single CCG. We had a launch event, we've had an online survey that's also been completed, hard copy, and we ran a number of pop-up events across the county of Shropshire and Telford and Wrekin area. Just to give you a flavour, at the moment the team are collating the responses from the survey and also the feedback we received on those face-to-face discussions with the public. But the general themes are from the 71 surveys that were completed, which isn't a huge amount, but given that this is ostensibly about internal restructuring and there is little impact on patient services, that's not surprising. The general themes were that there is general support, I think, across all of the areas making up Telford and Wrekin and Shropshire, of those people who replied, around recognising that a good way to make efficiencies is for the CCGs themselves to look to their own houses to save money where they can, and this is one way of doing it. There were concerns raised, however, around whether truly there would be any impact on patients, whether directly or indirectly. And I think that's something that we need to respond to very strongly, that that's not the case as far as we're concerned. The other area that was cited a lot was a concern that in some way people's voice or their needs would get lost in a larger CCG. And we heard that from rural populations, so I attended the Ludlow and the Whitchurch pop-ups, and also the Telford and Wrekin. And Telford and Wrekin, some of the feedback there was exactly the same. So I think there is something about the two CCGs, again, responding very clearly about how we think going forward we can make sure that actually the health services that we commission in the future are based on need and wouldn't be affected by where people
currently live, whether that's in a rural or an urban setting. The other thing that I would like to highlight from the report is in section 2.9, which is around some very specific proposals to change the current constitution of Shropshire CCG. As I've outlined in the report, the proposed changes we agreed at the last meeting in January was submitted to NHS England, NHS Improvement for ratification. And through that process, they highlighted that the current constitution doesn't actually marry up with recent guidance that they published, which was around the decision-making ability of Remuneration Committee and also the chairing arrangements for Remuneration Committee. So the current NHS England guidance basically says that remuneration committees should not be making decisions. They can only make recommendations to the governing body, and the governing body actually takes that decision based on those recommendations, and that there needs to be separation between the audit committee chair and the remuneration committee chair. So therefore it's advisable that the audit committee chair does not chair remuneration committee. So the proposal that I'm making is that we amend the current constitution along those lines, and I've outlined those in Appendix 1 with track changes so that it's very clear what we would be changing, and I'd seek your approval of those changes. And that's all I wanted to say, Chair. Happy to take questions.
Okay, thank you. So questions for Alison? No, I'd like to thank Keith for your work on the Remuneration Committee and then handing it over in such good form to Sarah, so thank you for that. As long as we can in a minute accept the amendments to the Constitution, subject to that. So we'll accept them.
I think I do.
So just one question about the engagement report. What do we do with it now? We've done the engagement report, and what do we
So at the
there?
moment, what we're collating is the engagement report. So good practice means that you collate all of the feedback and then you actually respond to that feedback. So I've already shared that feedback with colleagues in the executive team to start pulling that information together, and that would be incorporated into the engagement report, which would go with our suite of documents to NHS England as part of our application process, but we also propose that we will be publishing that on both websites of the two CCGs for transparency, so that people who may have offered their views on this can see what other people said as well and what we intend to do with that feedback, so that we're closing the circle.
Okay, thank you. So if there's any further questions, we're asked to note the actions taken to date on creating the single strategic commissioner. And then we're also asked to, as a board, approve the recommendation, the proposed amendments to the CCG's current constitution to ensure the terms of the Remuneration Committee meet recent legal advice and best practice. So are we happy to support that? Yeah. And then finally, we're asked to support the planned reapplication to NHS England improvement on the 30th of April to create a single CCG across the footprint of Shropshire, Telford and Wrekin. So anyone not approve that?
Thank you.
No, that's fine, that's brilliant. Thank you. I think you're now leaving it, Jan. That's
Thank
fine.
you
Thank you very much.
Chair.
So we now go back to paper 31, which is Claire presenting the clinical and financial report on the Quality Innovation Productivity Prevention Scheme.
Thank you. So the report that you have in front of you is our position as reported at month 10. I'm pleased to say that we have held our forecast position. So the reforecast that was made at month 9 is holding true. As you would expect in any finance position, we've got some ups and downs in some of the areas, but that's perfectly manageable within the totality of the budget. So nothing at this point at month 10 that was raising any particular concern for us in terms of that year-end number that we fixed. The QIP position itself also didn't move materially, so again our forecast for delivery in QIP is holding firm at around about 16.4 million. We do still have an element of net risk associated with that QIP programme, but again the management team are working to try and reduce that where possible so that we don't see any impact to bottom line. Work continues to look at the figures that we need to produce for our plan for 2021, and as we talked about in our closed session earlier, my intention at the moment is to bring a paper to the Finance Committee at the end of this month with a view to receiving sign-off of budgets from governing body in April. That at the moment is predicated on us agreeing a position with NHSEI that they are happy with for us to proceed with. As you can imagine, we're still working towards quite a significant deficit position, so we need to make sure that we can produce a credible position, but make sure that we're working as hard as we can to drive that number down, because we need to show that we have a clear trajectory for getting back to a balanced position over a period of time. They're probably the headlines that I wanted to flag. I do want to talk a little bit about the year-end accounts and part of the process that I need from you today, but if I pause before I do that, I'll take any questions on either the current position or plan.
Alan.
Yeah, what likely effect has the coronavirus outbreak have on our finances? Has there been any additional funding promised by central government?
So at the moment we have been asked to collect all costs associated with our work around the coronavirus project impact. We are working on an assumption at the moment that that will be nationally funded, so through SAM we're keeping a very clear record of every cost that's attributed to that.
Thank you. Any other questions? No? If not.
Okay, so if I can just pick up, it's the very last section of the executive summary. Those board members that have been around at previous boards will recall that at some point through the process of closing the accounts, I asked for a number of declarations from board members. It feels like this comes around faster and faster, and I think this is a little earlier than normal. But what we want to do is just make sure that we have a record of these declarations from board members now. Of course, right the way through to when we actually close our accounts, if any circumstances change and board members feel that this position changes, you have the right to say so and we can flag that. But just for now, we thought we'd capture the agreement whilst I've got everybody in the room, because May board feels a long time away at the moment, but it's going to creep up on us and there'll be a lot to talk about year end. So the declarations that we seek are no different to previous years. The first one is that we just want to make sure that board members are content that we are including everything that we should in our accounts to inform the production of our numbers. If anyone thought that there were items that we hadn't taken into account or that we hadn't made the auditors aware of, we'd be seeking for people to say, I'm not inviting that, I'm not suggesting there will be, but it's a chance for people to speak up now before we produce the numbers. The second ask is that we accept that the CCG is operating as a going concern. We have lots of conversations about this at Finance Committee and at Audit Committee. We're taking our assurances at the moment that we are, and certainly there will be a significant amount of content in the annual accounts that will describe why we make that assertion. So again, I'm not asking for anything difficult or extraordinary from board members at this stage, just to confirm that you recognise that. And then the third one, you will have all received a letter just making sure that you're aware that we will be making disclosures in the accounts around pensions and salaries, so it's the last chance for people to comment if they're not comfortable with that, although unfortunately we do have to publish because that's one of the mandates of being a public sector body. So I just open it to the floor really. I'll ask for exceptions rather than a specific comment from everybody. It's just to make sure that people are content that we can take a minute that people have supported that declaration. Wonderful. Thank you very much.
I think we've done both the actions required, which are noted, and then obviously we've just formally, I think, made those three declarations above, so that's fine. Thank you very much. We then move on to Chris Morris, who's going to present with Julie the performance and quality report.
Okay. Thank you. Obviously, colleagues will have read the paper. I just wanted to draw particular reference to positive improvement in cancer performance, particularly the 2-week performance, and we do believe that is, as much as we can do, staffing will be maintained. We have got the ongoing challenges around 62-day, which is inextricably linked to the more national position around urology. But again, we have been applauded by the regional alliance in terms of the partnership work that SAF are doing with UHNM. So again, it's well renowned that we're doing as much as we can, but we still need to be very mindful that that does have some limitations, and need to figure out what else we need to do and what we can do and what our options are through the alliance to improve that. With regard to IAPT, since I wrote the report, I noted that we'd requested from MPFT a query around why our IAPT access is fluctuating and it's not as achieved as consistently as for our colleagues in Telford and Wrekin. The Trust have come back with a response to that and say because the service in Telford is more established, so they believe the comms and promotion of that is more effective. They've looked to develop a similar plan for Shropshire, and they expect that to improve over the coming months, and they do still expect us to achieve the 22% for the year end. With regard to A&E, I just wanted to draw attention to the new process around the 12-hour breaches, which I'm sure if there's any more detailed questions, Chris is in a much better position to answer. But doing the desktop review of notes of patients affected has definitely given a much richer view of patient care and the results of extended waits on trolleys, and that can only add to improving patient care for the hospital. So I think that's a really welcome change to the process. And also to note that we have finally reconstituted our ambulance local working group with support from the ambulance service, so we now can focus on what do we need to do to support the reduction in conveyancing and also reduce the long ambulance waits, which you know is still of significant concern in our health economy. Happy to take any further questions.
Thank you. So, questions for Julian?
Sorry. I'm just concerned about the IAPT because the way, although you're saying that they're getting telephone calls quite quickly, actually counselling is still taking 5+ months for the match to be seen bodily, which remains a concern for us.
And that is picked up through the contract meeting. We are taking that forward with the provider, and we do expect over the next 12 months to see an improvement in that.
Can I ask a couple of questions? One is about the 52-week wait patient in Hampshire. And feeds a little bit into the questions that were raised at one of the last board meetings around monitoring of out-of-area contracts, because I thought we obviously were notified when you go over 40 weeks, isn't it, in terms of monitoring. Were we actively monitoring this patient, or did it come as a surprise?
This particular one did come as a surprise. Again, it's not a contract. This would have been a non-contracted activity. We wouldn't have a contract with Hampshire. It's a patient choice. They'd obviously, one of our patients had chosen to have their care there for all, whatever reason. And unfortunately, we didn't have sight of this until not until it was too late, but we checked with the Trust. They'd followed the correct procedure in terms of offering the patient an alternative. The patient wished to maintain and have their care in Hampshire, and therefore was treated within a month. But clearly, that's a challenge that we do face when patients do choose to go farther afield. More locally, and certainly within the Trust within the West Midlands, we do have a very good early surveillance of those over 40 weeks, and we are able to ensure that they follow due process. We had to ask retrospectively for this patient that they'd been offered choice and follow due process, but that was just because, as I said, we didn't know about it.
And over 40-week numbers, are they large or small? I mean, are they like
they're growing.
Or?
The over 40 weeks are growing, so it's becoming more of a challenge to avoid 52 weeks. It literally is now being managed on a patient-by-patient basis. Again, I'd say the two specialties that are most affected are oral surgery, which is commissioned by NHS England, but the one that the CCG commissions is urology. And again, at the moment, that is around managing the limited capacity that we have. Also, I'll be honest, we've made some inroads because we found issues with certain demand into urology services as a result of community promoted PSA testing, but we are making progress that both across Shropshire and Telford in that dialogue with charitable organisations to support them in what because their aim is well made, but it's their unintended consequences somehow of how that works. So we are working on that. But urology is a challenge, and we are literally, we know the trust are tracking that on a patient-by-patient basis to avoid 52-week waits.
And I was going to ask one more question, but there's other people. I'll let them ask their questions first. I've missed them. Deborah, and then Colin, and then
It was just a
John.
query in the part 2 of the full report. You've got an executive summary table with sort of red and green indicators. And for the primary medical care and elective access, there are 4 indicators, and you're indicating they're all red. But then when I looked through the body of the paper, I couldn't see why that was.
Bear with me, that might be, I think we might have a colour problem there. I don't believe so, I don't think there were any
Well, no,
reds on the
that's what
primary.
surprised me.
I think we've got yes, I've got the table. I think we must have put that in the wrong place. It's an error.
Thank you.
Apologies.
That's
I
good.
did spot there was an incorrect number. The numbers didn't add up for mental health, which I corrected, but I missed that one, Deborah. So yeah,
That's all right, as long as they're green.
Yep. yeah.
Colin.
Julie, bottom of page 15 on the report, there's a large number, 850 12-hour trolley waits for Q3, which, when I did a quick sum, told me that's about 10 in any one 24-hour period, which felt to me like a huge number, maybe because we don't see it reported in this way before, but can we be assured that we're doing everything we can to get that number down, because not least of all this is distressing to patients, but
Absolutely.
it's also dangerous for patients, I think.
Yeah, and it was picked up at the last governing body because we saw a significant increase in December and January. I'm pleased to report that the numbers did come down in February. There still have been 12-hour breaches in Royal Shrewsbury in March, but the numbers are reducing. I can assure you that certainly from the CCG point of view, we are pushing the trust as hard as we can. There remains a concern, I think, that we may well have normalised some of that, and we're certainly keen to make sure that that's not the case, that this absolutely should be by exception. That message was certainly also supported by NHS E&I at the last urgent and emergency care escalation meeting. So I think we have said that level is unacceptable. They are, as I say, they have improved. I must confess, I don't know if Chris might want to come in, but we were concerned about the level in January, considering actually that the relative demand dropped in January, and yet we still had a significant number of 12-hour trolley breaches. We saw that position improve in February, although demand did increase slightly. And again, there's differences in site. We seem to be managing, the hospital seem to be managing better at Princess Royal. We seem to be having, the vast majority of the 12-hour breach, I think all bar one month to date in March, and I happen to know this because I'm on call this week, have all been at Royal Shrewsbury again. So we are picking that up and through the A&E delivery group, and I know Chris will also be picking it up through the clinical quality review meeting. So Chris, do you want to add to that?
Yeah, so certainly the quality of care to those patients are in the themes of the risk summits that we'll discuss in the paper shortly. Clearly, as Julie says, it's far from ideal. We're one of the worst performing systems in the country for this figure. And we know that the trust could manage the care of those patients when they're waiting in a more efficient and dignified manner, which we'll come on to in the future paper, but it is of concern.
Okay, thank you very much.
John, and then we've got Alan.
Yeah, I'm not wishing to be repetitive. Mine really, thanks for the report. Mine was along similar lines, really. I noticed that figure of 882 trolley waits was a year-to-date total, rather than a month snapshot. But it was really how much, and you may be coming on to it, Chris, as to how much of an idea we've been given as to the cause of that, in terms of, is this indicative of of the inpatient group work being at capacity, is the hospital full, or is it a problem with the efficiency of transferring from that moment to admit? Is it an efficiency problem or a capacity problem, or a mixture? But noticing that the ambulance handover times had dropped, and which is positive, and just really a question as to how that's been achieved, what work has been done for that.
I'll answer the second part of your question first because it's easier. The reduction is purely linked to volume. We know we've had a report done by the CSU. The single biggest determinant of excessive waits for ambulance is volume, and not only that, the volume in per hour, because of the logistics of the two departments and how many ambulances they can physically manage. So we know when we get above that we have a problem. Because the demand and the conveyances dropped in January, we saw a corresponding reduction in the over-hour delays. What we've got to try, and that's why the improvement in the handover delays is inextricably linked to managing down the conveyances, and then obviously when we've got the level of conveyances that we think we can't improve, then we've got to work on how, what are the options that we've got around the logistics to then be able to cope with that number of ambulances and manage those handovers in within the 30-minute expected time. With regard to the causes of the 12-hour breaches, I think it's fair to say it is multifactorial and it is a combination. I don't think it is just about there are absolutely demand and capacity issues within the trust, and we know that, and that's reported that we had a bed gap, so that absolutely contributes to that. But equally, as I said, in January, the demand and capacity issue wasn't as extreme, and we still had a problem. So I think it is a combination of capacity, but also systems and processes, and that's reflected in the work that we're prioritising within the A&E delivery group, which is absolutely for 2021 is to focus on flow and including the systems and processes.
Thank you. Alan?
Yeah, well, can I ask about that? Because one way of addressing the long ambulance handover times and the long waits on trolleys is for patients to be taken to an assessment area separate from A&D. So they don't go into A&D at all. They go to either an enlarged AMU or a chest pain assessment unit or a care for the elderly assessment unit, whatever you like, so that this workload does not go through A&D. So I'd like to ask what progress has been made in providing alternative assessment areas so that patients don't have to go to A&D.
There's been significant progress because they've expanded. They've now adopted AMA, so the acute medical assessment area. There's also the same-day emergency care area. The issue is that invariably those areas are being bedded down, and therefore they can't take the patients directly. The challenge that's been made for our projects and our priorities for the next year is how do we work differently, and that predominantly within the trust, to protect those areas, those assessment areas, so they don't get bedded down, so they are able to do, just as you say, to take those patients directly and to take the pressure off ED. But we've kind of got occasionally get into that vicious cycle where they are already bedded down. We need to break that, and that's why we're doing a lot of work around the demand and capacity with the trust around actually what does the capacity need to be of those assessment areas, and make it of the right type. So with all due respect, it's kind of like it can be chairs. It's not an area that can be bedded, and then you protect that function and you protect the patients being able to be taken there directly. So it has been identified as a priority, and certainly it's linked to the work that the emergency care intensive support team have been doing with SAF.
Sure, but we've yet to see any real results, and we have very bad figures, national figures. So I just wonder how long it's going to take before we actually see an impact.
I don't know. I think we'd have to direct that question at SAF. I think that's not a question that the CCG is in a position to answer, I'm afraid.
Can I ask one more question, which is aligned, I suppose, with RTTs and weights and things, and it's it may be a little bit unfair to ask you when you may need to go away. It's about neurology.
Yes.
Where are we with neurology and the reprovision of a service within the sort of the boundaries of RSTP?
We have had some challenges with our negotiations with Royal Wolverhampton, and we had to escalate an issue in terms of a response. I've been informed recently that that's now been dealt with. They're finalising their detail of their offer to us, and I'd expect to receive that imminently, and then we'll bring that through our clinical commissioning committee when we've got the offer for subcommittee to review and to get those arrangements in place. But the delay has sat with our colleagues in Wolverhampton. We escalated it to the highest level, and now I believe we've got that resolved. But until I physically receive the offer, I can't say that. But I won't wait for another governing body. If it comes in the meantime, I will let colleagues know.
That's brilliant, thank you. If there's any further questions on Julie's paper, we're asked to note the contents of the report and the assurance sought from the CC actions to ensure patient safety and compliance. So thank you very much.
Thank you.
Then move on to Chris, who's going to present sort of a paper that goes alongside that, really, about the SAF, particularly around the SAF quality and the CCC update. Thank you.
Thank you. So we've discussed previously the history of the CQC inspections within the Trust since 2018. They visited the Trust again in September, and we're still awaiting the full sight of that, the publication of that report. But we know since that visit there have been further Section 31 breaches raised in relation to the Trust's registration. And as a result of that, a risk summit was held in December, when all system partners were asked to look at how they could possibly help manage demand away from the Trust, to try and reduce the number of 12-hour delays, but also to give the departments the additional capacity to manage safe and effective care. So an action plan was put in place, and a further risk summit was convened in January. At that point, it was evident that every partner had delivered the actions that were on that plan, but clearly that had no impact, because there were the highest number of delayed patients waiting for admission that there had ever been at that point. So clearly those actions weren't the right actions to address the root cause of the problem. CQC then went in February and did 2 unannounced inspections to the A&E departments and raised further breach notices in regard to the registration of the Trust, and they're detailed in the paper. Their actions are still being considered as to what they do. So the 3 bullet points under Section 3 are really serious options that CQC are considering in relation to the provider's registration, and will have considerable impact on our population. So a further risk summit was held in February, the 25th, which Maggie Bailey, myself and David Stout attended, and I think it's fair to say that risk summit was of a different tone, which was needed, I believe, and it involved stakeholders from Royal Wolverhampton, University, Hospital North Midlands, and a much wider stakeholders, with a real question from NHS of what can we really do to make a sustainable difference to the quality and safety of care at the Trust, and to enable the CQC to consider whether these actions in point 3 are actions they should really be considering. So after those the CQC visit was put in, the Trust immediately put in place an action plan to shore up safety over the weekends of the emergency departments, and myself and Jo Allen, Head of Quality, went in on the weekend of the 22nd, 23rd of February to test out that plan, to see in real time whether what the Trust said we're going to do was actually happening on the ground. CQC's concern remains around appropriate paediatric cover at the 2 A&E departments, and that was a feature of the Trust's action plan, and unfortunately that wasn't in place when I visited Princess Royal, and that was shared and discussed at the risk summit. University Hospital North Midlands have immediately stepped in to support the Trust with that. There's been some really positive actions from providers around our border to support the Trust, peer support has been put in place for a consultant workforce from Royal Wolverhampton, and some really positive work is in train to move the trust forward, which will be reviewed at a further risk summit, which will be held in 2 weeks' time. The date for that hasn't been set yet. At which point there will be a view of whether the actions that are put in place are going to provide the assurance that care is safe and effective in the emergency departments. CQC were very clear that what they witnessed, which is in the paper, was poor care, and that the trust need to take that in hand and actually move it forward. The new chief executive was present at the meeting, and she was absolutely committed, very open, transparent, as were the executives, to move this forward in the right direction, which was positive to see. I think what was clear was that the Safety Oversight and Assurance Group, which has been running for over 12 months now, which members of the executives have been in attendance, hadn't delivered the improvements that we'd hoped for, and so that meeting is being stood down in April, and a system improvement board will be established to oversee the improvement plan and actions that are going to be put in place. But it is very clear that it is the onus is on all partners in the system to make this difference, to support SATH, as well as SATH reviewing their internal processes and procedures to and monitoring and to sustain that for patient care. I think I'll leave it there, and I'll take any questions that you may wish.
Thank you, Chris. Start with Fiona.
Thank you, Chris. I was just struck by what you said on page 4 of your report, that during your visit you concluded the outcome was that paediatric nurse cover was not in place at PRH, and the audit outcomes and records reviewed continue to align with the CQC's previous findings. Given what you've said about some of the measures CQC have alluded to, how likely do you think it is that one of those restrictions is likely to be imposed?
I think where we got to in the discussions was that 18 months ago we talked about PRH closing overnight. It was very public discussions, and a lot of work was put in train to take, to consider whether that is the safest option for our population. And at the time, we didn't need to go to that extent because the resulting medical staff was found to shore up services. So one of the actions has been to revisit that plan to see whether that is something that we should be considering or not. So I think CQC are very open. They want to hear the progress before they make any decisions.
I think looking back 18 months, one of the issues is the proposed changes. Do they introduce more or less risk to patients and continuing in a service that at that time the service was related to staffing challenges, and it's a fairly difficult decision and involved the National Medical Director of the NHS coming to a meeting in Birmingham to actually coordinate the discussion. So those options are fairly stark when they're written down, and the pressures on patients, if one of them was enacted, are huge. The pressures on our neighbouring trusts as well. So it's to think about the effect, the knock-on effects of other places if these decisions are made. I mean, I think it is interesting. It is a very, very difficult decision, and there isn't an easy answer. And you can see that on page 2 out of 3 of your report, where there's only 4 substantive consultants in post. And about 2 years ago, we spent a long time talking about tipping points, and 4 is well below the tipping point that we had at that point. So I think it's important that these papers are here and we discuss them. But as I say, that no decisions have been made on any of these options. There is ongoing sort of work. So in terms of further questions, I've got Keith and Alan, I think, for questions, and John and Colin. Not Colin, no, just these questions. Deborah. Keith.
I understand the points you make exactly, Julian, but the report to me shows a deteriorating position and I wonder how much further down it goes. And as you said, Chris, it says about poor care, but at what stage does poor care become care that actually causes harm to patients, accepting the fact that some of the answers that might be imposed on the trust might actually cause problem for other parts of the system? What is it that we can do to protect the interests of the patients of Shropshire, Telford and Wrekin?
I think in order to lift the poor care up, it is about what I've seen happening in practice for the first time, which was positive. It is about actually the accountability of those individuals who are actually delivering that care. Nobody goes to work to do a bad job, but it's really important that every member of staff within the emergency departments takes responsibility for the care that they deliver to patients, and I know that they do, but there's sometimes when they're under pressure, things are not always followed through, and I saw some examples of that when I did my visit. But what I also saw, which was really good practice, was the audit process that the Trust have put in place now to audit sets of records in real time, and to go back and discuss with those caring for patients at that time what had been found, and actually, that how they can improve their documentation or their practice through that process. So that real-time feedback, I think, is a really good way of improving the culture of lifting up standards from what may be at a fairly low level to where the Trust want them to be. So I saw that work in practice, and that is a really positive endorsement of the work that they're starting to do.
Thank you.
Thank you. Alan.
Yes, thank you. You talked about the hospitals in Wolverhampton and Stoke assisting South, and I wondered if you could say where you think that assistance how it might develop. Might they, for example, end up being responsible for staffing the A&D departments?
Well, we didn't go that far in the discussions, but clearly their chief executives were at the table and were going to be working with the Trust and NHS England to look at how that networking that we're already doing across a number of specialities could support the Trust.
We've got Mike. I'll put you on the list. We have got John next, and then we've got Colin. We haven't got Colin. We've got Deborah, and then we've got you, Mike. So, John.
Yeah, thanks. It links in very much with the questions, particularly what Fernando asked as well. The third point that CQC considered about imposing a condition restricting the number of ambulances being conveyed to the emergency department of one or both locations. I realised that the previous assessments had been looking at whether both sites would remain open, and that was something that, and as Julian quite rightly pointed out, has other consequences. I was really wondering whether that third point from CQC was at the request of the Trust to be considered, or purely something that was generated as a potential solution by CQC in relation to Section 31 breaches, and how far that idea has been progressed, whether that has been modelled in any way.
Well, we do know that our ambulance services, when we are under pressure, look at what they call intelligent conveyancing, where they will take the patient in the ambulance to most appropriate A&E department for their care. We know we have patients, right in the north of the county, that it isn't very much further to go to one of the Cheshire Trusts, or to or those in Telford to go across to Wolverhampton. So really, this was about encouraging the ambulance service to look at where they're taking patients. But this is one of the standard points that CQC would look at for any trust in this position. It may be that ambulances would just go to one site and not to both sites as they do currently. They're really waiting for the system to come up with what are the alternatives before they consider imposing any of these actions.
Thank you, Deborah.
Thank you. It was just this is obviously a system-wide problem, and it needs input from the whole system. And we've heard this repeatedly over the months and years that this situation has been going on and gradually getting worse and worse. And it seems to me we hear a lot about what the system must do, but some of this actually does need to come from SAF. And some of the actions are very specifically things that actually it's not for the system to do, it's for SAF to do. And those just don't seem to happen. You know, for example, being told very clearly that you have to have a paediatric trained nurse on duty at all times in ED, but there wasn't one. No amount of system input is going to support that, and I think we're all trying, but sometimes it does feel as if SAF is almost helpless, and I'm wondering what we can do as a CCG and a governing body to address that, to hold them to account, to support. There's a kind of learned helplessness response going on here that almost needs to change. So I don't know what the answer is, but I felt it was a question that needed to be asked, and whether we need to ask SAF to come to us and tell us what they're doing about those things.
One of the things I was going to say from Chris's report is you said that at the previous meeting the whole list of actions were done, but we know one of the problems is SAF haven't done the whole list of actions that have come through numerous reviews they've had either from ESIST or from other support people that have come in and done reviews. So there is an element of where system partners are doing their actions, but SAF aren't. And I think that's one of my things. When you look at the dates of the CQC visits, I think November 18, April 19, there was a visit, and I think they went to A&E then as well, didn't they? Yeah. And then September 19 and February 20. And now we're talking about going in and looking at notes to make sure we can, correct individuals when they may have done things wrong. Well, this isn't those individuals' fault. They have a professional duty as healthcare workers to act within their professional responsibilities and to do the appropriate things, but ultimately they're being placed in a situation. So I do worry that has a knock-on effect on the morale, on the staffing, and also we're possibly, we're part of that assurance process. We aren't looking higher up at where the problems are. And I know they've had change in leadership at SAF, but at what point do we say, well, actually, how do we need to, or are we, or is someone looking at that leadership capacity and capability within the organisation to bring about change and to actually embed change and learn from mistakes?
I think just to go back to your point, which is linked to your comments, Julian, the CQC did say that a lot of the issues that they found are for the trust. They're in the trust gift to sort, and I was sort of recognised that was really clear, and the chief executive absolutely acknowledged that. So I think the trust have got policies, procedures, protocols, but what was evident was that those protocols are not being followed. So my reference to some individual practice was that the trust need that leadership at every level in the organisation to ensure that the protocols and policies for safe and effective care are being put into use every day by every member of staff.
And one aspect of the main CQC review in September 19 is one category is well-led. Do we have any indication yet what the well-led review says? Because presumably we had a review of the well-ledness, whatever the right word is.
That's right. We haven't had any feedback on that yet, and I think the report should be with the trust shortly for them to check for accuracy, and we would expect it to be published following that. So it will be. I don't know what the well-led is going to say.
Mike, I think you were on next on the list of questions.
Sorry, very quickly, there was an article on the telly last night about Wolverhampton and all the ambulances going there, which I thought was quite an odd report, because I couldn't, until I actually listened to it fully, I couldn't actually work out what they were talking about. But they're essentially blaming some of the underperformance in Wolverhampton on the fact that there are more ambulances coming from Shropshire to them. So I don't know. I take that with a pinch of salt. And
I think we've seen that in the activity guides. In the finance report, one of the areas, unfortunately, Claire's gone off coughing, which isn't so good. She's got her tissues here, which is good. But one of the things about is the emergency activity at Royal Wolverhampton Trust has risen, and that's one of the factors in there. So we do know, and we do know that the ambulance will, through their intelligent conveyancing, we'll look at where the waits are and we'll move patients around if they need to. And I think Wolverhampton will have seen an increase in ambulances from from Shropshire because of the delays. So yes, they would have done.
Just saying that I think, and turn back to Alan's point, the only way the system will work here is not actually blame, because I felt that there was some blame in the article on the TV towards Shropshire, but I don't think that gets any far, and I think the accident departments have to work together. That's Stoke, Wolverhampton, Chester, everywhere has to work as a team, rather than just blaming somebody else for what's actually happening.
Thank you.
Thank you. Are you all right, Claire?
Yes, thank
Do
you.
you want to sit in the
Figured you
corner?
didn't want me spluttering everywhere.
Are there any further questions on this, which is quite obviously a very significant and important target of our attentions, really? And SOAG is going, and what's replacing SOAG?
System Improvement Board.
And is that SOAG with a different name, or is it? Or how is that different?
Haven't seen the terms of reference yet for that meeting. So hopefully it's an improvement on SOAG.
Can I ask one other question? You might not want to answer this, or Jess might not want to answer this, but one of the reports back we had was that SOAG was effective and that we were having positive reports back from the hospital about improvements. And yet, when CQC go in, they don't see them, and obviously when you go in over a weekend and look, you don't see them either. And has that been addressed? Do we understand why we thought things were improving when things weren't improving?
I think Dave Evans wrote a letter to NHS England, an improvement to ask how can we as CCGs work more effectively with the regulators to get more robust assurances, because what was being discussed and presented in the SOAG was not always what we were seeing in practice. So that has been taken on board, and certainly there's a recognition that the SOAG hasn't done what it needed to do, and that's why it's being changed.
Okay, thank you. So I think unless there's any other questions or points, I think we are just asked to review the content of the report and identify further assurances that may be required. I'm not sure we've identified other than that there is a need to be ongoing, and we are waiting for greater, wider system input, wider than just the Shropshire Telford and Wrekin report. So thank you. Moving on to the next paper, where Fiona Ellis is going to give us a presentation on the update on transforming midwifery care.
The report actually presents a summary position across a number of different key programmes related to maternity. Just in summary, really, we continue to work closely with staff as the maternity provider, as well as others, to deliver progress and improvement across service delivery, as well as the wider strategic transformation objectives. But the pace and scale of change isn't as far as long as we'd like it to be. Maternity services are continuing to be under scrutiny, and it's really having a knock-on effect now in terms of those wider transformation programmes. So you've got some of the detail there in the report, and I'm happy to take any questions or comments.
Okay, thank you. So questions, Alan?
Yes, thank you. We had some data provided to us at the Quality Committee a couple of weeks ago, which concerned me a little bit. So we learnt that there had been a couple of serious incidents in maternity in December, and that our caesarean section rate was still well below national average. And it just made me wonder, what measures are we using to assure ourselves that maternity care is improving? And what do those measures show?
Okay, so in terms of the quality assurance process, Chris might be able to support me with this as the director leading that area. But we've recently revamped the quality assurance process that we were undertaking. So as well as a programme of scheduled visits, we recently also undertook an unplanned visit, an unannounced visit. We have a contract quality and review meeting every month for maternity services, where we receive a broad range of information, and are strengthening our assurance around that now as well. More recently, we've asked a midwife advisor to work with us more closely as a CCG, so that we've got that midwifery expertise available to us as a CCG, so we can provide that challenge back to the trust with a very specialist focus from a kind of maternity midwifery perspective. So that's really helping. Chris, I don't know whether there's anything else to add.
I just wondered, what are the 4 or 5 key indicators that we're following, and what do they show?
Well, the key indicators around the stillbirths and neonatal deaths are encouraging, and that the trend continues to be in line with the national trajectory, so that's really positive. But whenever there are any serious incidents or areas that aren't performing as well as we'd like them to be, we do then follow that up and look at the reasons behind that. And we're working with the trust to see if there's a different way of reporting information, so it's easier for us to then look at what the reasons behind that data might be.
And patient satisfaction, how are we measuring that?
We measure that through, so there's the recent CQC questionnaire that's come back with patient satisfaction. We also gather feedback through the Maternity Voices Partnership, through the local maternity system. We're just in the process of recruiting a number of volunteers across the county who will be routinely gathering information from women and their families across the county. In the recent unannounced visit we did a few weeks back, we spoke to a number of families, both mothers and fathers, and they were all overwhelmingly positive about the service they've received.
Sarah.
Hi, thanks, Fiona. I just wondered if there was any realistic timeline at the moment for when the national panel might be approving one of the Transforming Care. I know it's been a long time coming, but have you got any timeline for it?
No. So we continue to chase through regional maternity colleagues at NHS EI to understand what the timeline for that might be. We had expected our proposals around transforming midwifery care to be heard on the 28th of November. They weren't heard then, and we haven't yet had a date as to when they will be heard. So we are continuing to ask that question more than weekly, but we haven't had an answer. Whether it will be heard or when it will be heard, we haven't had a response at all.
No, frustrating. Thank you.
I've got, sorry, Keith and then Finola.
I'd just like to reiterate that point. I think it's completely unacceptable, the amount of time that it's taken to get an answer, whether it's positive or negative, and I wonder whether we could send something more formally from the governing body to NHS England to say that we are distressed at the delay to try to move to the next stage of this, because this affects us getting improvements that will affect the women across the whole of the area. So I think it's deeply disappointing. And then just to add to Alan's question about patient satisfaction, that was a CQC survey, wasn't it? And it did show that South was, I think it's described as among the pack. So I think given the circumstances, I think that's a really positive result, and it does reflect well on the work of the whole of the midwifery team across South, so I think we should recognise that as well.
I think it's reasonable to write about our frustration about the delay, and so I'm happy to take that away and then work with David to write a letter to NHS.
I think it's really important because we recognised in that review, we recognised that there is currently inequity in the service provision. We also recognise that there is instability in the current service provision and that it doesn't meet the requirements of the National Transformation Agenda. So we know that what we've got isn't delivering what we need. We know what we need to do to change that, but we can't do that. And we're also now seeing frustration from the provider's point of view. We've got a new director of midwifery in who's very keen to start to drive forward some of that transformational change. And at this point in time, we're not able to support some of that change that she wants to implement. And actually, we agree that needs to happen, but we need to ensure due process is followed. So I think whatever we can do to keep pushing back to the decision makers would be really beneficial.
Finola.
I was just clarifying what you meant by no answer. So clearly, we're not getting an answer at all, and completely.
So as far as we're aware, the proposals haven't been heard by national panels. So they've been heard by several different panels. So the West Midlands Clinical Centre have received them and approved them. Regional NHSEI have received them and approved them. And the first national board have received them, and we're due to be taking them forward for approval to final national panel, but that hasn't happened. So it's just we don't know what's happening. We haven't heard of a date when it will be heard, if it will be heard, or what the answer is.
And it sounds like you're contacting them regularly.
Yes.
Are you getting a response?
From local colleagues, yes, I understand. I think Jess had a conversation the other day with our regional NHS EI colleagues, but they don't know what's happening either.
Okay, so they probably feel similarly frustrated.
Yeah.
Any further questions? I've perhaps got a question. One is a slightly different area, but it's about smoking cessation in pregnancy, and it's about the current state of that service and moving forward into the next financial year. I wonder if there's any, because that was a key sort of LMS type priority, wasn't it?
It is. It's a key LMS priority. There are two elements to it. There is the element around actually what substantively should be existing in our system regardless of transformation activity. and that at the moment is a real challenge. So in the long-term plan, there was an inkling in there that actually it would now be the NHS's responsibility to commission that service. At the minute it sits with public health teams and local authority. As such, the public health teams have stepped away from funding those services, where whilst it continues to be a high priority for us as a system. So we're currently having discussions across providers and commissioners to find a resolution to that. We haven't yet got a resolution to that substantive smoking cessation provision. But the local maternity system continues to deliver transformation activity around enhanced peer support around smoking cessation. We're starting some social prescribing projects, upskilling midwives, doing a lot more work around training and awareness for a broad range of professionals. So there's lots of work still going on to continue to improve the smoking cessation rates. But there are two different elements. There's the what should be in place anyway, regardless of the LMS, and then what more can the LMS add to that to seek additional improvement.
Thank you. Mike?
Yeah, sorry, as I understood, you are still getting smoking cessation from health authority? Or who are you getting it from?
At the moment, the Telford and Wrekin Public Health continue to fund a post in for Telford and Wrekin women, and continues to be a smoking cessation service for Shropshire women as well. But that is under threat now, given what was in the long-term plan around it becoming an NHS responsibility rather than public health.
We understood when the other services got stopped that one was going to continue. And there was no restrictions on it, and that was one of their priorities. Are you saying that's not happening?
I'm saying it's not clear now. I think the direction from national isn't clear, and the local position isn't clear, because certainly public health colleagues locally aren't digging their hands deep in their pocket to continue to provide that service. I don't know whether anyone else has got more of an update in relation to that.
Can I add to that? I think actually what was agreed, Mike, was that notice was served and it was agreed that the service would continue for this year. What was meant to happen was that agreement was meant to be reached about how we would then recurrently provide that service from the beginning of April. I think the point Fiona's making is that that agreement hasn't been reached. So at the moment, services are in place until the end of March. As I understand it, the council have agreed to continue to fund the community element of it. It's the element that is provided within, from the midwife-led and the acute service that still has to be agreed. Whereas we were at a disadvantage because Telford Council hadn't served notice. They now have served notice, so I understand their service is at risk from the beginning of April as well.
So if I could just say, so Dave is in the process of writing to both local authority managing directors to get a clear position from them and see how we can work together on this. And also we've put in a challenge through the local maternity system escalation process to say, it does say in the long-term plan that this women should be able to access NHS funded smoking cessation services, and so is there likely to be funding that follows that pledge, and we haven't had a response to that yet.
Okay, thank you. And unless there's any further questions, then thank you, Fiona, for all the work you're doing and the ongoing work, and thank you for coming to present to us. And we just have to note the content of the report. I now plan to have the break that we were going to have, and that we'll reconvene at 2:30, so a slightly longer break, for an extra 5 minutes to enjoy the coffee. Thank you. Sorry, that's fine. If we could take a seat so we can get on with the second half of the meeting, that would be good. Thank you. That's fine. That's good. That's good. We will start the meeting, and then I'm sure we'll have time to enjoy the hot water within very soon, because I think there's only a few papers left to do. So we're going to swap the papers around a little bit, because Sam has some further phone calls. So Sam's going to kick off this sort of second half with the Emergency Preparedness, Resilience and Response report and update. And it's 2:30.
Thank you, Julian. So there's a paper that's been prepared that's within your pack, so I'll largely take that as read. So if I give an overview of where we're at locally in terms of our response to coronavirus, we have been very closely following national guidance, which, as you will imagine, is developing fairly rapidly as this situation emerges and evolves. We have responded to all the requests within that guidance in terms of local response arrangements. So we currently have assessment pods in place at both hospital sites. We have home testing arrangements in place, and as of tomorrow we will formally have drive-through testing available within Shrewsbury, and plans are afoot for that to be implemented within Telford as well, and assessments will be undertaken as to whether we then need to roll that out across the county. We have arrangements in place with our providers in terms of escalation should we need to implement that on the basis of evolving government advice. So we are in a good position locally in terms of our ability to respond. So in terms of the current local position, I can confirm that as of today we have 2 confirmed cases within the Shropshire area, both of which have recently travelled to this country from Italy. The cases, however, are not connected. So we are in contact with Public Health England, who are carrying out the necessary contact tracing and support for these individuals in order to ensure that the impact is minimised. So I think it's important to reiterate that we are in line with international trends, likely to see an escalation certainly of people presenting for testing, although to date the numbers presenting have been low. So people, I think, should not be alarmed by this. Just because somebody presents for testing doesn't mean that they're a positive case. And positive cases are being reported relatively quickly, and there are developments in place in train to ensure that positive results can be established within 24 hours. It's taking a little longer than that at the moment. So I think we can reassure the public and ourselves as a governing body that the situation currently within Shropshire is low risk. We do expect this to evolve over the coming days and weeks. We'll continue to push messages out to the public and internally in terms of updates. I think we also just need to reiterate that the best method in terms of protecting oneself in relation to coronavirus is good hand hygiene. We can't stress that strongly enough. Everybody could take the opportunity to reinforce those messages wherever possible. I'm happy to take any questions.
Okay, Sam, thank you. Thank you for the work you're doing at the moment. In fact, all the executive. I know it's we have had to develop a 24/7 response team aligned to NHS England's response team. So it is a lot of work, and I think obviously if you look at the trend in Italy and other countries, this is something that will rapidly accelerate and is, as you say, something that's changing on a daily basis. So thank you. So any questions from the governing body? Perhaps if you could just briefly say what the around the sort of the work we're doing with our partners locally. Really, is that worth just saying? How that that emergency response, the emergency preparedness. I can never say the word.
Yeah.
How that exists and why that word is quite a challenge.
So as I've alluded to in the paper, we have an infrastructure that's been set up around this topic to support the work that we're doing and make sure that we have a coordinated multi-agency approach. So I think the paper sets out a range of partners that are involved in that local health resilience partnership arrangement. That's the forum that steps up if we have an issue of this particular nature. So that's been mobilised and is meeting twice weekly in order to manage the situation as it evolves. So we are in regular contact with all our partners across the sector in terms of the part that they need to play in the coordinated response. So working very closely, particularly with the hospital trust and the community trust in terms of their responses, and clearly they are fully involved in the assessment and testing arrangements that we're rolling out locally. We're also in discussions, as you would imagine, with the care home sector, out-of-hours providers, etc., to make sure that we have a full and coordinated service to respond to this, and that we can escalate that in line with national guidance should we need to. At the moment, as I say, the local situation is that presentations for testing and numbers of positive cases are very low. And the response therefore is proportional, but we are in a position to escalate our response should we need to do that. But we are very much relying on business as usual until such time as the guidance changes.
I think from a patient and also from colleagues' sort of point of view, the key thing is if you've got questions about coronavirus is to use NHS 111. Ideally, use it online. You can also look for information on the nhs.uk website. There is a dedicated website for professionals which gives links to information for both primary care, secondary care, and also dental and optoms, and also sort of care homes, and that's just the NHS England website with a link through, and that's searchable on Google. But the key thing for patients is, if you think you might have coronavirus, you think you're unwell, do not present to a GP surgery or to A&E. You ring 111 or you go online and access 111 and fill in the form, and that will give you advice. Obviously, there's a list of countries which are type 1 countries where if you've travelled back from, you need to self-isolate. They are updated, and that includes the whole of Italy, Hubei province in China, parts of South Korea and Iran, the whole of Iran, and then obviously the other countries, the type 2 countries, the ones where if you travel back from, if you develop respiratory symptoms, then you should sort of self-isolate and contact 111 online. But I think the key message is do not attend sort of healthcare facilities, the MIUs or A&E or GP surgeries. Use the online services and 111 phone line first.
Yes, and there is the whole raft of guidance out there for anybody who has any concerns, both professionally or personally, and that is changing quite rapidly, as you would imagine. But there is a significant amount of support for people who might have queries or concerns. And yes, just to reiterate, 111 is the route in if you have any concerns. So that would be the route into our assessment pods, our community home testing, or our drive-through testing is all through 111, who will make an assessment in terms of what the patient is describing or the individual is describing as to whether they need to self-isolate and be tested or not. And until such time as there is a confirmed positive outcome, we would be treating people as a negative case and interacting appropriately.
Okay. Thank you. Alan?
Can I just ask,
Meredith?
just ask whether the orthopaedic hospital has been asked to consider how it might be able to help, both in terms of bed capacity and anaesthetic support for intensive care at South.
Yes, Robert Jones is engaged in the conversation and has focused internally on its own plans and getting those in order, and we are now moving into a phase of looking at how we can work cross-agency to make sure we've got the appropriate response in place. But yes, they are engaged in the discussions.
Because their anaesthetist might be very helpful to the intensivists at South if things get difficult.
Absolutely, yeah.
Meredith.
Thank you. So first of all, thank you very much, Sam. Communication has been excellent, and your presentation today and regular updates and clarifications and so forth have been very, very good. So well done indeed. There's always a risk of inaccurate or imprecise information leaking out, and then people start running hairs are set running, and it's people start operating under a misconception. Are you kind of monitoring the flow of information that goes out from other sources and thinking, hang on a minute, that's a bit ambiguous, or that's not absolutely right, and then taking opportunities to correct it? I mean, it could be an industry in itself, so I understand that's quite difficult, but just kind of making sure that what is actually out there is always clear and correct.
Yes, we are attempting to do that within reason. So we are aware that there is a certain amount of misinformation that's circulating, and we're trying to counteract that with more official information that we send out, both from the CCG and also particularly from the local authority, and making sure that reiterates national guidance and points people in the right direction in terms of where to get the appropriate evidence-based advice to support their concerns. We're also aware that there is the potential for social media to have an influence in terms of that misinformation. NHS England have become aware of this as well, and there is now sort of centralised route in order to feed up any issues in relation to social media that we're concerned about around misinformation. But I think I would stress that if people want information about coronavirus, they shouldn't go to social media channels necessarily. They should be looking to the official sites through NHS England, through the .gov site, and through Public Health England. If you want to know accurate information, those are the places to go.
Thank you. Any further questions? If not, Sam, thank you very much for that update, and we'll move on to the next paper, which Claire, deputising for David, is going to present on the CCG Strategic Priorities update.
Yeah, thank you. So this is the latest update on the priorities that we set back at the start of the financial year. And per conversations that we've had previously in requests, we've now also added a high-level KPI to each of the areas. I'll take the paper as read. I'm assuming that everybody's had a look at what's in there, but we'll sort of invite questions if anybody's got any based on the content that's here. All the updates in the table are in red.
Sarah.
Yeah, just on the planned care one, MSK, are we confident about the timeline for the rollout of that? I think it's 1st of September for the single model of care. How confident are we on that?
As confident as we can be at this stage. I'm waiting for the next Alliance Board to have the detail of the plan. Originally, the providers mooted a kind of date of the 1st of July, which did feel a little bit optimistic, and I'm more than happy to encourage them to be enthusiastic but realistic. So I think now they've gone through it in some detail, the 1st of September is much more likely, but until we've had the next Alliance Board, I can't confirm the details of those plans. But that's the view that collectively they've come to.
Good. Thank you.
Thank you. Any further questions? I think it'd be nice to hear a little bit more about the rollout of the case management pilot going to neighbouring practice with the rollout to the whole of November, and is there any update about how effective or non-effective we've found our sort of case management pilot. Yes.
Hello. Yeah, I mean, case management, we're really pleased actually. In the last week or so, we've been able to get some much more robust data that shows the impact that it's having. So that'll be coming through to CCC this month for sharing, and then we can share it more widely once it's been tested there. But it's looking quite impressive. And the particular good point around that really is that we're only currently working in 8 out of 53 practices across the footprint. There's a lot of scalability in that. There's also the fact that we've only currently got 42% of the eligible patients actually consented for case management. So once we iron out within, you know, recognising IG limitations, once we iron out the process for consenting people for that and can increase that as well, then there is quite a large capacity there for significant impact, helping people stay well at home and making sure that they don't need secondary care services as much as they currently are doing. We've got plans to roll out to neighbouring practices. We've actually today found out that we've got the next 8 practices lined up. So again, that will be coming through to CCC, but it's really positive. There are practices that are kind of knocking on our door now to be involved in the next wave. And this is a very short-term measure before we start rolling out across the whole of the STP footprint within this calendar year. It's one of the identified STP priorities, which means that we should all be putting our efforts into this. We've agreed as a system a number of priorities, a smaller number of priorities than are described in the plan as a whole that we will focus on in this next year. This is one of them. So when it comes to a bun fight over resources, this one should be one of the ones that we actually put our backs behind and start pushing forward. So it's really positive we've got those 8 next sites lined up, but that's a very short-term measure, and we hope to have the full rollout across the system as a whole by the end of this calendar year. That's the plan.
That's good. No, thank you for that update. Any further questions from anyone? If not, I think we're just asked to note the contents of the our update on the strategic priorities. The next paper is then Keith Timmis. We've moved to paper 38, which is the summary of the audit committee.
There's just a few points I would like to particularly bring the governing body's attention to. It was very encouraging to receive 2 more internal audit reports that concluded with significant assurance and shows the continuing improvements in the arrangements we've got within the CCG. We received a draft plan from internal audit for the next financial year, but we did express some concerns about some of the changes that were in it, and we've requested a review of that with a further meeting with lay members to make sure that it meets all the issues that we think need to be covered, and we expect to receive an updated version of the plan for the audit committee in April. We approved the external audit plan for the current year's accounts, and there's nothing of any great note to report to you yet on that. The reassuring news on fraud was that the National Fraud Initiative has now been completed and no instances of fraud have been identified. So again, that should give us assurances about the processes we've got in place that make us safe from the risks of fraud. The committee also agreed that we would no longer require reports on the approval process for interim staff. Those with long memories will remember we introduced this because of concerns that came from NHS England about whether we were doing the business cases in an appropriate time and whether we were following all the rules. I think we feel assured now that the numbers of interims have reduced dramatically, and all the evidence shows that overwhelmingly all the processes are being run effectively. So we didn't think it needed particular attention from the audit committee, but it would still be something that Kevin's keen to keep an eye on from the finance committee perspective. And then if Kevin's got concerns from that, then it would be referred back to the audit committee to consider whether we need to reintroduce that process. That's the main things I wanted to raise, unless anyone's got any questions from the report.
No, thank you very much. Any questions from anyone else? No? If not, thank you for that.
Thanks.
There then follows a series of reports that are for information only or for questions exception reporting. So that's the CCC from the 20th of November and the 22nd of January, the Finance and Performance Committee from the 27th of November, 9th of January and 29th of January, Primary Care Commissioning Committee 4th of December, Quality Committee the 27th, A&E Delivery Board the 19th of November, North Locality Board in November and January, Shrewsbury Locality Board in November and January, and the South Locality Board in in November. So if anyone's got any questions that have arisen from those minutes, if not, that's fine. I've not been notified of any other business. Sorry, Meredith.
May I have one very quickly, please?
Of course you can.
I know we don't normally do this, but can we give Chris and Jess a big round of applause for all the work they've done for the CCG? Would that be all right? Anyone disagree?
Yes.
Thank you.
I assume that was an AOB rather than a comment on the paperwork. Yeah, thank you. Yeah. The date of the next meeting currently is Wednesday the 13th of May, at a time and a venue to be confirmed. So thank you very much, and we'll close the meeting. Thank you.